What's going on, everyone? Good morning. Good morning. I wanted to go through and talk about something that I think will be really helpful for you with your patients. If you want your patients to get it, sometimes you have to explain some of the clinical stuff. You got to take an unfamiliar principle and make it familiar, connect the dots for them so they have an aha moment. So I'm going to give you guys a second, guys and gals, give you a second to jump on here. Let me just share this over so I can get some notifications out so everyone knows we are doing this. Give me just a second. Let's see. Stand by. All right. A lot of you might be getting ready to go into the clinic right now, or maybe depending on if you're on the East Coast, you're already seeing patients. But I go in this afternoon on Wednesday, so I do some work from home right now, and I wanted to start the morning by going through something that I think is a really important and helpful topic that I remember when I first learned this, it was an aha moment for me because it helps make sense of things, which is what the concepts of functional movement really help do. I feel like it helps bring this stuff to light or to life and to light so that you understand why people become dysfunctional and why muscles are tight and why people have pain and certain movement patterns that are not right, and then how to fix them. So here's what I'm going to go through. Let me unshare my screen here so I can make this a little less clustered. That was a sneak peek. So if you want your patients to get it, you want to explain overactive synergists. So first off, let me pull up some text here on the screen because I think that is helpful in keeping us on track. All right. So I have some notes over here that I wrote before I started this. So I said in this title here, in this description, admit it, your patients don't follow your recommendations for one of three reasons. Okay. So it's either they don't trust you, they don't trust that your methods will work, or they don't trust themselves to actually follow through. We talk in other videos how in Move Now University, we have the systems to help them follow through, and we have the organization to help you and your team execute these systems. So it's going to work as long as you can connect the dots. And real quick, if you haven't followed our stuff in the past, or if you want to find out more information, check out our 30-minute pre-recorded demo at demo.movenowu.com. It's a 30-minute pre-recorded demo. You can see inside of our portal. I go through it step by step, explain how it's laid out. You'll get a better idea if this resonates with you and if you think that this is going to fit into what you're looking for. And then you can schedule to talk with one of our team, or we can get on, answer more questions, and then help you ultimately get to the decision if this is right for you, if it's in your future, if you're a good fit for our team, and if we're a good fit for you. So demo.movenowu.com. All right, let's get rolling. So again, I'm just going to say there are really three main reasons why a patient doesn't follow through. Either they don't trust you. So there's something about you that you just didn't develop trust and rapport. We talk about this in our communication lessons that we run through. This one's a clinical lesson today, so I'm not going to dive into that too much. Second thing is they don't trust that your methods are going to work. Or the third thing is they just don't trust themselves that they're actually going to follow through. Maybe they're the person that gets a gym membership and then never goes to the gym. And so if you can show them that there are systems put together, very intentional systems in your clinic, such as a online membership site that your patients follow along with, as far as a journal that they follow along with, as far as a reward system, as far as them ascending through a organized belt process, a belt system of functional movement, they can see that the systems actually touch on those motivating factors that get someone interested and keep them interested to actually follow through. That's why we did all this stuff, is because we understand humans are humans, and you can have the best systems in the world, and if someone doesn't do them, then are they really going to get the benefits that you know they can achieve? The answer is no. So that's why you have to have these things in place. All right. So again, I'm just turning to my notes. So I'm reading some of my notes here. So a great way to further build trust and rapport is to break down unfamiliar principles by making them familiar. Okay. So again, this post isn't meant to be a communication lesson necessarily. We do that in other ones, but more of a clinical summary of understanding the common talking points. These are things we talk about every day that help your patients understand, AKA below their minds, and finally make sense as to why they're presenting in your clinic with a problem and why you're going to help be the solution for them, where maybe other stuff has failed. So like these these pieces that we talk about are very intentional and they're very important. And if you're not getting the follow through with your patients, if you're not getting the results that you're looking for, you may be missing some of these things. That's why we're touching on these. It's not just all about communication. It's not just all about having good processes. It's about educating your patients as well and helping them find the motivation inside themselves and connecting the dots. And again, building trust and rapport. All right. So let's run through this. This next piece that we're going to talk about is, here's a step-by-step process that I tried to distill down, and then I'll show you a chart and go through an example of this, which I'm going to go through the example of shoulder issues, common shoulder issues, and how I can relate this with a shoulder problem. We oftentimes explain this with either a shoulder problem or a lower back hip dysfunction, depending on what the patient has. And we point this out, we touch the muscles, we explain this to them, we might draw a little picture, we give them an analogy. I'm just going to share with you how we do this because it's been very powerful. So the first thing that we do is we establish this whole thing of common patterns of inactivity or weakness. So let's say your patient has a shoulder issue, okay? And they say, oh yeah, I went to my physical therapist. They said I have a rotator cuff problem, so I just have to do these exercises until I throw up. And it's boring, and I don't like it, and I don't get it, and I don't understand why I need to do this, and I just want to go to the gym and work out, or I just want to get back to my normal life. So what you have to do is break down for them is you have to say, Mr. Jones, Mrs. Jones, here, I'll say Mrs. Jones because my last video I did, the example was all male. Let's do female. Mrs. Jones, there are common patterns of inactivity or weakness or dysfunction throughout people's bodies. There's common things that we see with people every day because of our positions, our work activities, just how our bodies are built, maybe exercises that we're not doing, ways that we're not using our bodies. So there's very predictable ways that things break down, okay? So what you have with a shoulder issue is extremely common and extremely predictable and extremely mishandled, unfortunately. And so let's say she's got rotator cuff issues, all right? So in this example, what we're going to talk about is there's lots of tightness in the front. So like pec minor tightness, there's internal rotation of the shoulders. There's maybe a forward shifted shoulder, so a protracted shoulder. There's maybe a hyperkyphosis, forward head translation, upper cross syndrome type stuff, right? They sit behind a computer all day long and they're stuck in that position. So that's a very common thing. Now you have a shoulder issue. So if you go and do traditional rehab or therapy, what do? They maybe stretch you out here, teach you posture, and then activate some external rotators. And there's a lot of things missing in just doing it like that. One is explaining it to the patient so they understand. But on a side note, two is looking at spine, obviously, breaking it down into segment, posture, movement. So there's three categories that we look at in Move Now. This is how we teach this. This is how we teach patients as well. So looking at segmental issues with our chiropractic adjustment, which is why, in my very biased opinion, I feel like chiropractors should be leading the industry in teaching about and fixing corrective exercise and functional movement, because we have such a great understanding of the spine and spine mechanics. So segment. Posture is looking at things like if the person has a structural postural hyperkyphosis in their thoracic spine, maybe they have actually traumatically induced and they have compression fractures, and there's things that have to be looked at to see how much can you change that posture with things like traction and specific posture corrective exercises. Maybe the person just has a adaptive screwed up posture because of abnormal, work position, and their spine is still rigid and hyperkyphotic, and it needs to be addressed with more than just exercise. But you absolutely have to adjust and get movement into fixated or restricted segments, aka subluxation. And you have to do traction to actually stretch deep muscles and remodel ligament and deep supportive tissue around the spine, more than you're going to achieve with just exercises alone. Okay, so that's my little side rant on that of why chiropractors should be doing this. So now, those are things that we may touch on briefly in this moment, but the main thing that we're trying to connect the dots on is that there's patterns of inactivity and weakness, and it's very common what you have. It's because of position, and let me explain to you what things are going to be weak. Okay. And so let's see our next talking point here. Okay, let me finish this real quick. So as far as patterns of inactivity or weakness or common muscle groups in the shoulder, all right, that are inactive or weak would be the things that hold the shoulders back and down. So not to get too much into the scapula, but the scapula should be stable and should be retracted and depressed to keep this nice upright posture. It also sets up your glenohumeral joint for having good movement. So again, I'm not explaining these terms to a patient. I'm just saying this from doctor to doctor. Like, these are thought processes. So the scapula needs to be back and down so the shoulder can have proper range of motion so that the scapula isn't rocked forward, tipped forward, causing the acromion process, that bony shelf, to actually create a bony obstruction to getting into full overhead flexion, for example. Okay. In the case of internal and external rotation, though, very common thing that happens is that people are weak in their external rotators. They're weak moving into external rotation. Now, why is that? How does that happen? This is this process of understanding overactive synergists, weakness, pain, reciprocal inhibition. I'm going to cover this here step by step. So let's share this little graphic. This is something that we made inside of our level 3 overhead deep squat assessment. I'll just give you a sneak peek. This is inside of our Move Now University program, and you go into measuring movement section. We have 4 different levels of movement assessment. We have level 1, 2, 3, 4. 4 is extremity. 3 is a overhead deep squat assessment. And in the overhead deep squat assessment, this is a little drawing that I put this together back in the day. There's 5 different dysfunctional faults that can happen in an overhead deep squat. One of them is the arms can't stay upright and they fall. And so now, why is that? Well, I built out a little graphic to talk through it, and I'll further elaborate on this topic right now of inactivity and overactive synergists and reciprocal inhibition. These are like those 3 things of inactivity and weakness, overactive synergists, reciprocal inhibition. Those 3 things, if you really understand that and you can apply it to different parts of the body, you can explain this stuff to patients and you can blow their mind. And that's what we're going to geek out on with the shoulder here. All right. So if the arms fall, the thought process is, what is that? That is an inability to externally rotate and flex the arm when you go into a deep squat. So if you can't externally rotate, you go to this next little spot right here. Hopefully you can see my mouse. Yeah, there we go. You can see it better. All right. That means that there's likely tissues that are tight, short, and overactive. And our method needs to be giving the patient protocols to tone down and lengthen those tissues if that's the case. So what tissues are tight, short, and overactive? They're the internal rotators of the shoulder. That can be from a postural issue, sitting in a bad position, and then you have what is called a adaptive shortening. Okay, so if they're in a shortened position, those tissues just stay short. And mind you, when I'm talking about muscles, it's not ever just specific individual muscles. It's muscles in groups. It's the connective tissue around there. It's the musculotendinous junctions, and it's fascia overlying. So just like Thomas Myers showed us in anatomy trains, which talks about these fascial planes and these slings of muscle, that is probably the best representation of how things work, but it's still okay to be able to break down and talk about individual tissues. It's a combination of looking at all of these things. So just want to throw that caveat out there for those of you watching this who are super into planes of movement and fascia and that sort of thing. Definitely has its place, extremely important. But for right now, we're going to stick with talking about and identifying individual muscles. So tight, short, overactive internal rotators. And so and then what are those internal rotators? Well, there's the teres major, latissimus, and subscapularis. You can geek out and try to figure out which one of those tissues is most responsible. There's a differential diagnosis called a lat length test. I'm going to flip over here real quick. Inside of our program, just to give you an idea of how we teach this, is we have like an overview video. I actually wrote out the thought process here. This is how this stuff comes to fruition, is that we write this out and then we make the nice graphics and then we make training videos on it. Okay. I go through how to do a lat length test. So this right here shows. Okay, there's three things we're trying to differentiate here. Is the reason that our patient can't get the arms fully overhead in overhead deep squat because they're restricted in this internal rotation. So you get the picture. We run through it. I show it with trainer Tony. All right, lat length test. And then we do some upper body strength tests. And then we show some real specific exercises and releases and things. But let's get back to this. So again, internal rotators are shortened, overactive. We need to identify which ones they are if we want to get into that much detail. And then we have to figure out how to get these tissues to loosen up. But the next part of the understanding is figure out what type of muscles control the opposing joint action. So if they're tight in internal rotation, this common pattern is external rotation is weak. This is a common pattern, that again, hyperkyphosis, forward head translation, upper cross syndrome, adaptively shortened muscles in the front, weak muscles in the back. Why are the muscles weak in the back? And that actually goes into this other topic. Let me pull it up on the screen here. See if I can do this quick enough. Let's see, scroll down. Okay, and hang with me here, hide. All right, that goes into this topic of overactive synergists. Actually, I'm not there yet. Hold on, hide that thought. So if internal rotators are tight, overactive, you're going to have weak and inhibited muscles on the other side. This is actually called reciprocal inhibition. So I maybe put this out of order. I should have talked about inactivity weakness, reciprocal inhibition, and overactive synergists. I should flip that order around a little bit. You got me. All right. So reciprocal inhibition means that, for example, and this is how I explain it to a patient, I say, you can't flex your bicep and flex your tricep at the same time. When you flex your bicep, your tricep has to do what? You ask them that question. They say, relax. And you go, exactly. So if your muscles in the front here are always flexed, if they're always tight, then the muscles in the back that are supposed to do their job, guess what happens? They can't fire properly. You move improperly. You have stress on the joint, the tissues, your shoulder breaks down. Okay. So do you think all we do is strengthen these muscles in the back? No, it's not that simple. There's a couple pieces of this equation that really need to be worked out. So one is we have to loosen up these, but in the same session, then what we need to do is we need to take these weak and inhibited external rotators. So in this case, teres minor and infraspinatus, and you can confirm their weakness doing a muscle strength test, like it says right here. But in most cases, they're going to be massively weak. We show how to do that muscle strength test. And then what you do is you start to activate. And there's some specific ways of doing the exercise to do that. Like, for example, if you just externally rotate, then you're oftentimes going to recruit overactive synergists, which overactive synergists are the tinier little muscles that are less effective at doing their job. They will try to take over. They're probably already taking over. They are tight. They are painful. That's maybe a huge explanation as to some of your posterior shoulder pain is these tight overactive synergists. And so you don't want to take the overactive synergists and make them more engaged. You want to get these prime moving muscles to actually engage. And so how do you do that? Well, that's where you get into some of the specifics. And for you as the doctor and your staff understanding it, and then explaining bits and pieces to the patient as you instruct them on exercises, that's what makes all the difference in the world. So for example, if you are doing and I'll keep this chart up here so we can explain this. Let's say that you're doing external rotation exercises, right? If you just have them get a band and pull an external rotation, that's the only thing that they're minding in their head, they're likely going to just contract lateral delt, rear delt, and that's how they're going to get from point A to point B. And the lateral delt and the rear delt really is not the one that should move your arm backwards like this primarily. You want those other stabilizing muscles and those little intrinsic muscles that help go through that movement, which is your teres minor and infraspinatus. You want them to be doing their job, because if they don't do their job and they're not strong enough, they're going to be weak and painful, and they're going to allow more instability in the shoulder joint. And ultimately it's going to lead to injury and dysfunction. Okay. So what you have to do in this movement is you have to use some of these concepts of like reciprocal inhibition, for example. The old, if you flex the bicep, you can't contract the tricep at the same time. What do I mean by that? If you just externally rotate here, like I said, you're going to probably fire lateral delt and rear delt. You don't want to do that. You want to fire teres minor and infraspinatus. You want to get those strong and active. So if you take a little towel or a little spacer and put it between your elbow and your rib cage and you adduct. If you adduct while you're externally rotating, what does that do? That adduction is going to reciprocally inhibit. It's going to make it neurologically impossible for you to be contracting your lateral delt. So now you take your lateral delt out of the equation just by adducting. Cool. That's the little towel trick. Throw a towel here while you're externally rotating. There's another piece you can be even a little more specific because your rear delt's still going to try to kick in. How do you get your rear delt out of the equation? You go into a little bit of shoulder flexion. So instead of you just being upright neutral, you come into maybe, 15, 20 degrees shoulder flexion, and then you adduct. And when you do that, it actually reciprocally inhibits, it takes out the rear delt from this motion of external rotation. So now it's forcing you to activate those two weak external rotators, teres minor and infraspinatus. And you're not going to be able to do a whole lot of weight with this because those muscles are likely very weak, and you'll be targeting those muscles specifically, and you'll be on your road to starting to rebuild proper shoulder stability and rehabbing, strengthening the shoulder properly. But in the whole vein of how we do things with, I'll throw this up on screen too. In the whole vein of how we do things with functional movement, we don't just end with this rehab exercise. We end with a patterning exercise, and we want to load the patterning exercise if the person's able to do it non-painfully. So you can see how all of these little rules and laws of functional movement overlap. Like in a previous training we did, we talked about the 4 laws of functional movement, and you never want to exercise a painful pattern. So let's say at the end of this, things are moving pretty well, and you say, I want to take a kettlebell or a band, and I want to do overhead shoulder pressing. And I want to use all the different principles of like strong first, which is what we embrace. And we encourage people to learn more about strong first, but we take the principles that they talk about, which completely blend perfectly with all of the functional movement stuff and all of what all the research supports. So it's like really nice to have a strength and fitness and technique group like Strong First with kettlebells align with all the functional rehab and functional movement research and expertise out there on the rehab side and marry those together. So there's a process of going through with a shoulder press, for example, with a kettlebell. That would be a way that we would pattern this movement towards the end. Or we would pattern the movement, maybe if they can't go overhead, we would take like a band and we would have them really retract and depress the shoulder blade and go into a rowing movement. And then maybe even a rowing movement with a little bit of external rotation at the end. Okay. So those would be ways to pattern the movement once you get things active. And that's how we always try to end our session when we're working with a patient. And that's how we teach them to engage in their home care as well. And so we're teaching them these things so that they can be empowered to follow this in their daily routine and live with certainty, and be encouraged that if you follow these things, you can rebuild your body stronger. So that is the main thing I wanted to cover. These videos always go a little bit longer than I plan. In my mind, I'm like, how can I go through this in 10 minutes? And then you realize that, well, it takes a little bit longer because it gets a little bit in depth. And if I don't go into this much depth, then I think I sell it short and I don't complete the thought. So I'm not trying to just be really vague in this. I'm trying to give you some good content and help connect the dots here. So anyway, the title that we started with was Want Your Patients to Get It, Explain Overactive Synergists. That was the hook to get you to watch this. Hopefully you watched it and enjoyed it. It's really talking about common patterns of inactivity and weakness, reciprocal inhibition, and overactive synergists, and you understanding it so well that you can draw a little picture for a patient. You can explain it. Now, it's not usually you as the doctor explaining this. That's the thing. because it might take you 5 minutes to go through the explanation. You're adjusting your patient, you're sending them back to your exercise department, and your exercise staff understands these concepts. And you know that there's only so many examples in the body where this happens. I mean, there's common patterns that happen. And so it's not like there's a million different possibilities with this. If you understand how to explain this, primarily, like the most common thing you're going to see is with the shoulder and with the lumbopelvic hip. There's a couple other ones too that we can run through in the future. But if you understand those two, that's the most common thing that you and your team are going to see on a daily basis. So anyway, Dr. Todd from Move Now You, I got to get ready to do the rest of my morning here. I got a lot that I get done before I go into the clinic. We're going to talk about time management stuff here in some future videos too, because I'm taking on some new time management processes that are working really well that I want to share with you. Check out our demo if you haven't already, demo.movenowyou.com, and follow our stuff and put comments below and let us know what else you want to see. If you have any questions, if you like the format of this nice short 25-minute video. All right, over and out.